Welcome to our sketch on the differential diagnosis of vaginal bleeding in early pregnancy. Vaginal bleeding at any point during a pregnancy is very concerning to a patient, and while it doesn't always mean something's wrong, it's very important to take it seriously and do a full workup to determine the cause of the bleeding. Looks like we just stepped into one of those paint and Pinot nights at our local art studio. Let's see what these artistes are up to. In this sketch, we'll go over vaginal bleeding that occurs in early pregnancy, which is defined as less than 20 weeks gestational age. For now, we'll assume that the patient has had pregnancy confirmed and is now presenting with a chief complaint of vaginal bleeding. For each item on the differential, this sketch will focus on the characteristics of the patient presentation that should make you either move that item up or down on your list. After we go over all the things you should consider when you encounter vaginal bleeding in early pregnancy, we'll move on to a quick review of a typical patient workup for this presentation. Okay, now on to what you came here for, the differential. We're going to use a diagnostic tree to help us organize our differential, and the first branch is going to be whether or not you see an intrauterine pregnancy, or IUP, on ultrasound. We're going to place all the items in our differential where you do see an intrauterine pregnancy underneath our TV showing this woman with a flower that has a little gray oval on a dark background to represent an IUP on ultrasound. Over here on this other TV, there's nothing playing and the TV is off, which will symbolize no IUP seen on transvaginal ultrasound. All of the items in the DDX where you don't see an IUP on ultrasound will go underneath this TV. From here on out, we're going to divide the differential diagnosis for first trimester vaginal bleeding into three broad categories: viable pregnancies, non-viable pregnancies, and vaginal, cervical, and uterine pathologies. If there is a fetal heartbeat seen on ultrasound, this is considered a viable pregnancy. This is in contrast to non-viable pregnancies, which we'll cover in a few minutes. In this viable pregnancies category, we have instances of bleeding that continue on to normal pregnancies. The first one of these is called a threatened abortion, represented by this teacher that looks like she's threatening to kick some people out of this class. Maybe it wasn't a great idea to have that unlimited red wine. Anywho, for patients with viable pregnancies, the patient will complain of vaginal spotting, but the transvaginal ultrasound will show a normal fetal heartbeat, and on speculum exam, the cervix will be closed. We'll represent this with this pink pot that has its lid on. Her vitals and CBC should also be normal. The majority of these cases do not end in pregnancy loss, and the bleeding from a threatened abortion is thought to come from a small separation between the uterus and placenta. This presumed etiology is the only difference between threatened abortion and the next type of viable early pregnancy bleeding, which is called implantation bleeding, represented by this painting of a plant. Like threatened abortions, there will be spotting but a normal heartbeat on ultrasound and a closed cervix on exam. Really, the only difference between a threatened abortion and implantation bleeding is the cause of the bleeding. For implantation bleeding, the cause is thought to be the egg implanting into the maternal decidua 10 to 14 days after fertilization. This is really a diagnosis of exclusion, but one that you'll still want to have on your differential. Now moving on to non-viable pregnancies. We'll split this category into two subcategories: spontaneous abortions and ectopic pregnancies. First, we'll cover the spectrum of spontaneous abortions. These are non-viable intrauterine pregnancies that are somewhere along in the timeline of being expelled. These women will all complain of having vaginal bleeding at some point, and the non-viability is distinguished by either no fetal heartbeat or a dilated cervix on exam, which this early on in pregnancy means that the pregnancy cannot continue. To distinguish between the types of spontaneous abortions, pay attention to whether or not the cervix is open or closed and where within the genital tract the products of conception, again, also known as POC, are. Though technically vaginal bleeding is not usually a feature of this first type of abortion, it's worth noting here because your findings on exam may support this diagnosis over another, and it's a type of spontaneous abortion. What we're talking about here is the missed abortion, represented by this misty painting. A missed abortion is characterized by an intrauterine pregnancy with no fetal heartbeat and a closed cervix, which again, we're going to symbolize with this pink pot with a lid on it. Basically, there was a very early intrauterine fetal demise and the tissue has not yet passed. Another type of spontaneous abortion is called the inevitable abortion, represented by this painting titled Inevitability. Ooh, looks like that wine is making us get deep in this class. These patients will complain of bleeding, which we'll remind you of with these red wine stains on this canvas, and cramping, represented by these red lightning lines. On exam, you'll see cervical dilation but no tissue that has passed because the POC is still inside the uterus. It's called an inevitable abortion because the cervix is open and the pregnancy will inevitably pass. Now, here's where it gets a little confusing. We're going to continue talking about the types of abortions that fall under the larger spontaneous abortion category, but we're going to shift over here underneath our TV that's turned off, because for these types of SABs, no intrauterine pregnancy is seen on ultrasound. If you catch the miscarriage a little later in time, this is called an incomplete abortion, represented by this incomplete painting. Again, the patient will complain of bleeding and cramping. On exam, the cervix will be open, but this time the contents of the uterus are in the middle of being expelled, so there will be some POC in the cervix or vagina. To symbolize this, we have a plant that looks very much like chorionic villi just coming out of the top of this open pink vase. Finally, a completed abortion means that all products of conception have been expelled from the uterus. In this case, the patient's bleeding and cramping has usually stopped, but they should mention that they experienced a lot of both in the not-so-distant past. On speculum exam, you'll see POC in the vagina, which is why the flower in this painting is out of the pink uterus vase, but this time the cervix will be closed, which is why the vase has a lid on it. Besides spontaneous abortions, the other type of non-viable pregnancy that causes vaginal bleeding is an ectopic pregnancy, which is a pregnancy that implants outside of the uterus, usually in a fallopian tube. We're using our recurrent symbol for ectopic pregnancies here, the ectopic baby keychain. This important topic has its very own sketch, so head on over there for the nitty-gritty details of how to work up and diagnose an ectopic. Here, we'll quickly review what you need to know to diagnose it or rule it out compared to the other things on this differential. These patients will complain of light spotting and lower abdominal pain, which is why there are many red lightning bolts on this pink backpack. On transvaginal ultrasound, there will be no intrauterine pregnancy seen, but a beta-HCG level will be above the discriminatory zone, usually 2,000 milli-international units per milliliter. We're going to remind you of the important role the beta-HCG level takes in diagnosing an ectopic with these beta sunglasses hanging on this backpack. If you suspect an ectopic, you should take this very seriously. And if it hasn't ruptured already, rupture could be imminent, which causes a lot of internal bleeding. Make sure to assess these patients' vitals and note any hypotension and/or tachycardia. Now moving on to structural causes of bleeding in early pregnancy. You should consider these based on your exam findings if there are no signs of early pregnancy loss, such as absence of the fetal heartbeat or a dilated cervix on exam. One of the more common structural causes of bleeding during this time is acute cervicitis, represented by our recurring symbol, the lower portion of a uterus chandelier that's aflame. These patients will complain of postcoital bleeding, and on exam, you'll see a closed cervix with a friable, which means it bleeds easily, ectocervix. Your patient also may or may not have mucopurulent discharge coming out of the os. Cervicitis is usually due to gonorrhea or chlamydia, so you should test for them if the cause of early bleeding is not clear and treat if positive. While doing your speculum exam, make sure to inspect the entirety of the vulva, vaginal walls, and cervix for any lacerations that could be causing bleeding. Many times this can be due to trauma, so if you find these, make sure to question your patient about any possible instances of violence she may have experienced. Assess the volume and briskness of bleeding. If she's hemorrhaging, she may need surgery. If not, vaginal packing or expectant management may be appropriate. If you notice any abnormal-looking growths on your pelvic exam, you should perform further studies, such as a biopsy if it's safe, to rule out malignancy. A common non-malignant neoplasm that can cause vaginal bleeding is a cervical polyp. On the other end of the spectrum, cervical, vaginal, and vulvar cancers can all be a source of bleeding, and if proven, oncology should be brought on board. Now that we've gone through our differential, let's quickly go over a typical patient presentation, what questions you should ask, and what objective findings to look out for. In terms of the vaginal bleeding, make sure to ask your patient to quantify how much bleeding she's having. Is she spotting or is she soaking through pads? As this will let you know if you have an emergency on your hands, or if not, can give you a hint as to what's going on. You also want to ask when the bleeding started, how long it's been going on for, and if it stopped. Other associated symptoms that you'll want to ask about are cramping, the location and characteristics of her abdominal pain if she has it, and whether or not she's noticed passing of any products of conception, which is a combination of the fetal and placental tissue. When working up a patient who has the chief complaint of vaginal bleeding, pay attention to these things on your objective findings. On vitals, note whether the patient is showing any signs of hemodynamic instability, such as low blood pressure or tachycardia. This may influence how quickly you move towards management. In terms of physical exam, you'll want to do an abdominal exam, noting if there are any signs of an acute abdomen, such as severe pain, rebound tenderness, or guarding. Most important is the pelvic exam. Do a thorough bimanual and speculum exam. Again, note whether or not the cervix is dilated and if you see any products of conception in the cervix or vaginal canal. We already talked earlier about the all-important transvaginal ultrasound, but just to remind you, this is going to be the first test that you do, and the one that will help you with that first branch of our diagnostic tree. Like we mentioned before, note if you see a viable intrauterine pregnancy with a normal fetal heartbeat, an IUP without a heartbeat, or nothing at all. In terms of labs, obtain a baseline CBC. If the woman is bleeding heavily or you suspect an ectopic pregnancy, you may decide to trend the CBC, which means to get a new value every 4 to 6 hours, to monitor the amount of blood loss your patient may or may not be having. As a part of your blood test, make sure to add in a type-in screen to determine if your patient is Rh negative so that you can give her anti-D-immunoglobulin, aka RhoGAM, if she is. If there's evidence of an intrauterine pregnancy on ultrasound, there's no need to obtain or trend beta-HCGs. However, if there's no IUP, you should get a quantitative beta-HCG to rule out an ectopic pregnancy. We'll go over how to trend beta-HCG values and the expected trends in normal and abnormal pregnancies in our ectopic pregnancy sketch. Finally, if you do see what you believe to be products of conception in the vaginal canal, remove it and perform what's called the float test. This is to determine whether or not what you have are the products of conception or just blood. If it's POC, when placed in water, you'll see tiny vesicles floating. These are the chorionic villi from what was the placenta. While this bedside test can help you determine whether or not the patient has passed the pregnancy, you'll still always want to send the tissue that you have to pathology for final confirmation. Well, that's it for our DDX. Lucky for you, all the things we mentioned here have their own sketches that delve deeper into the risk factors, workup, and treatments for these conditions. For the management of early pregnancy loss, head on over to our sketch Spontaneous Abortion and Recurrent Pregnancy Loss. And for the management of ectopic pregnancies, we have a sketch for that too. It's called Ectopic Pregnancy. We hope you learned a lot here at this Paint and Pinot night. Maybe just that wine and painting don't always mix? Or at least that's what the lady who got stabbed with a paintbrush told me. Anyway, stay safe, kids, and see you next time.